Okay, so good evening to you all, and I welcome all the attendees to this very interesting masterclass session that Yashoda Hospital and Department of Critical Care, being headed by Dr. Venkatraman Kola. And we have been doing this masterclass from many years now and very well acclaimed sessions that we have here. So I welcome you all to today's masterclass session. I'm Dr. Karthik, and I'm a critical care consultant and head of critical care here at Somajibuda Yashoda Hospital branch. And every Tuesday evening, we bring forth interesting, relevant, and up-to-date topics in critical care, which are presented by our critical care residents. And the residents' presentations are examined, and their expert opinion is given by our seasoned examiners who are experts in this very field for whom we cater all around the globe in bringing them to you for this interesting session. So today we have a very important topic, that is a topic of weaning failure. All of us wean patients from ventilator. All of us, some patients get weaned quickly, some patients take time to get weaning. So today's session will be on this very important topic. We'll look at factors what cause weaning delays, what you as a critical care physician might keep in mind or do therapeutic intervention in order to avoid weaning delays. And to discuss all these topics on today's case presentation, we have Dr. Bharadwaj and Dr. Shravani. Dr. Bharadwaj is a pulmonary medicine fellow and IFCCM resident here at Yashoda Hospital, High-Tech City. Dr. Shravani is our DRNB CCM resident from Yashoda Hospital, High-Tech City. They will be presenting the case today. And to examine the case, we have seasoned examiners today for this masterclass session. Dr. Suresh Ramsubban needs no introduction. Sir is an eminent faculty, a DRNB examiner, and pulmonology and critical care expert from Apollo Hospitals, Kolkata. And we have Dr. Shweta, who is a critical care consultant and an intensivist from Colchester General Hospital, East Suffolk, North Essex Foundation Trust. So she's joining us from United Kingdom today for this session. So let's start this session without any delay. And I hand over the platform to Dr. Bharadwaj and Dr. Shravani to take over the case presentation. Over to you.
Thank you, sir. Good evening, one and all. Today we'll be presenting a case of a 44-year-old male who's a known hypertensive and diabetic who is non-compliant to the medications. And
Dr. Suresh is waiting, I think. He's waiting just...
Yes, sir. I think he has messaged me.
Yeah. Please, somebody from the
digital
team, is anybody there? Digital team, can you hear us?
Yes, sir. We are here, sir. Yes.
Can you just add Dr. Suresh?
Dr. Suresh Ramsubban.
Yes, sir. I made him a panelist, sir. He is joined.
Suresh sir, welcome you on board. Can you hear us? I'm not able to see him. Is he there?
He's there in the attendees, sir.
Yes, sir. He is not yet accepted the panelist.
Yeah. Accepted. Suresh sir, welcome. Unmute yourself, sir.
Am I visible now?
No,
And
sir,
audible?
Audible. Yeah,
Yes,
visible
sir.
and audible both.
Yes,
Wonderful.
sir.
All right. Sorry about that. I don't know why my laptop front screen is suddenly decided to give me trouble. So there was no camera. So I had to disconnect and connect it to my phone. Hopefully should be clear.
Yes, sir.
I hope there's no
All
noise
is
around, na?
Yes, no noise around. All is good to go.
All
Sir,
right. Thanks, sir.
Sorry
about the delay.
On the first slide, sir. Thank you.
Good evening, sir. We just started. We have a case of a 44-year-old male who's a known hypertensive and diabetic and non-compliant to his medications, and is a chronic alcoholic. presented to the outside hospital with complaints of yellowish discoloration of the eyes since 1 week, epigastric pain since 1 week, and altered sensorium since 3 days, following a binge alcoholic episode. He was managed conservatively for acute pancreatitis in the outside hospital. In that admission, 2 days later, he developed shortness of breath and he was initiated on BiPAP support. And after which he had an episode of vomiting. And in view of worsening respiratory distress, a patient was shifted to ICU and intubated and put on mechanical ventilatory support. Outside labs were showed evident of a left derangement with the total bilirubin elevated to 8, direct being 7, and enzymes were within normal range. CT abdomen done that time suggestive of a groove pancreatitis, cholelithiasis with the GB sludge and the CLD changes. He has received a methylprednisolone of 60 milligrams for treatment of alcoholic hepatitis. 4 days later, patient developed shock, and in view of worsening shock and decreased urine output, he was shifted to our hospital for further management on dual vasopressor support. On examination, patient was moderately built and nourished with the icterus present and bilateral pedal edema was present. He was sedated and paralyzed. Heart rate observed was variable with 144 to 156 tachycardia. AF with FVR was noted. And saturations, he was maintaining 94% with 100% FiO2 with PEEP of 6. And blood pressures with systolic 110 and diastolic of 70 on noradrenaline of 0.7 mics per kg per minute and vasopressor of 2.4 ml per hour. And he was febrile with 102 degrees Fahrenheit temperature. On respiratory system examination, he was having right basal crepitations with the abdomen distended. Bowel sounds were heard. No evident fluid thrill or shifting dullness was noted. And in view of AF, synchronized cardioversion was done with 150 joules. And further, it was recurrent. So repeated episodes of shock was required. And routine blood workup was sent, and 2 sets of blood cultures were sent, and ET cultures were sent. The X-ray, which was visible, which was done in the outside hospital just before shifting, was showing left-sided CP angle blunting, and it doesn't match the PF ratios in our setting with 83 and ABG suggestive of a mixed respiratory acidosis, a mixed respiratory and metabolic acidosis with the lactates of 7.8 and creatinine of 3.1. 2DCO was done showing mild LV dysfunction. This was a CT was done in our hospital, initial presentation, which is showing bilateral dense consolidation in the lower lobes and ground glass opacities seen diffusely. Ultrasound abdomen done in the bedside, suggestive of a cholelithiasis with the GB sludge, with large calculi measuring of 7 mm, no IHBRD or CBD dilatation, and a feature suggestive of pancreatitis was seen. Based on this, our provisional diagnosis was made as alcohol-associated pancreatitis with MODS, septic shock with MODS, aspiration pneumonia with severe ARDS, and suspecting DCLD too. He was initiated on antibiotics and stress dose of steroid was added, and ventilatory parameters was increased. PEEP was increased from initial 6 to 10 PEEP, and CRRT was initiated as per nephrology advice. And initial lab workups showed mild leukocytosis with mild thrombocytopenia, with the procalcitonin being 11, deranged INR with 2.7, and urea was elevated to 62, and deranged bilirubin with the total 9.41 and direct 8.74. With SCOT SGPT mildly elevated, with amylase of 418 and lipase of 1485. Sorry. Day 2, his GCS was evaluated found to be E3, PT, M5, and his NORAD requirement was persistent but decreased minimal.
So what sedation is he on at this point in time?
Sir,
GCS E3, VT, M5 with what?
it says fentanyl infusions.
Okay. So better to use a RAS score or something. Anyway, so what I want to know is, was he awake, alert? E3, VTM5.
He was drowsy, sir.
Arousable, sir, but not obeying commands at this point.
Okay. So,
He had
so how do you,
sir,
okay, not on paralytics anymore, I
No,
believe.
sir.
All right.
he
All right,
had
go ahead.
he had recurrent episodes of AF with FVR, and synchronized cardioversions were administered as and when required. He was continued on ARDS ventilation. The FiO2 requirement has come down to 0.7. PEEP was constant at 10 centimeter water, and he was continued on CRRT. ABG was suggestive of mixed respiratory and metabolic alkalosis, and lactates have come down to 3.3. The labs were suggestive of neutrophilic leukocytosis with further deranged INR and deranged RFTs, as well as bilirubin stagnant at 8.
Yeah, can we go to the next slide?
Just a second, we have.
Just wanted to know on the CRRT, were we removing any fluid or what were we doing with the ultrafiltrate?
Ma'am, as the shock is improving, the ultrafiltrate was at like 30 ml per hour at this point.
Okay.
The following day, the respiratory parameters have worsened with FiO2 requirement jumping up to 1. And shock was persistent, but he was requiring minimal NORAD support at this point, and he was continued on CRRT. By now, ET cultures have come, and carbapenem resistant Klebsiella has grown, and he was escalated onto Astriona mavibactam. And following this, one session of proning was done. The X-ray following this has improved to this. On day 4, the NORAD requirement has come down further, and ventilatory parameters have improved. PF ratios have improved to 278. Electrolytes were within normal limits. At this point, CECT abdomen was done, which showed cholelithiasis, an overdistended gallbladder, and no IHBRD with a query of cholecystitis. Medical gastro and surgical gastro opinion were taken at this point, and they have suggested on a conservative management. And following this, SBT was given with pressure support mode, and RSBI was 90 at this. And however, he had.
All right, my favorite question. How do you do an SBT?
Sir, we chose pressure support mode. We got down the pressure support to 8 centimeter per watt, 8 centimeter water, PEEP of 5, sir.
So is that how Dr. Tobin described this whole thing?
FiO2 less than 40% and
FiO2 less than 40%. PF ratios have improved to 278 at this point. So he was requiring FiO2 of only 30%, sir.
All right. So the ideal way when this was basically described by the University of Loyola with Dr. Martin Tobin. So the way they did this was basically either using a handheld spirometer connected to a endotracheal tube while patient is breathing room air for 1 minute without any ventilator assistance, or you do a pressure support 0, PEEP 0 for 1 minute, and the tidal volume can then be determined by the ventilator. These are the two methods that they do. So when they do pressure support 8 or automatic tube compensation, that is not the ideal way in which a SBT is performed. So the number 105, which you are looking as the RSBI or the Tobin Index or whatever you call it, it came from that one seminal paper that in the multiple number of studies that you. So what is the cutoff of RSBI?
105, sir.
105. So that means a negative indicates that the 105 means that he is.
If it's more than 105, then it's a failed SBT, sir.
Okay. All right. So he is basically put back on controlled ventilation. All right. So what did you do to assess why he failed?
Sir, the electrolytes were normal at this point. So we predicted a 2D echo because he was in AF with FVR, and he had hemodynamic instability with hypotension requiring vasopressor supports. So if there is a decompensation with heart failure, we've just assessed for it, sir. But 2D echo was normal.
What was the heart rate before? So before you started the SBT, it was in sinus rhythm?
Sir, he was in sinus rhythm before, and it was around 80, sir.
And what happened to the oxygenation?
The oxygenation was still normal, but he just had hemodynamic instability, sir.
So he developed hemodynamic instability, but he also had a rapid and shallow breathing.
Yes, sir.
He developed two things.
He was tachycardia.
All right.
Were the other criteria for the readiness for SBT assessed, and how are they?
Ma'am, sensorium wise, he was drowsy, arousable, obeying commands at that point, and pH was normal, ma'am, and PF ratios have improved as well. The primary pathology being ARDS, which we were suspecting, that has improved. So hemodynamic stability was there prior to initiating this.
SBT.
Yes, ma'am.
And neuromuscular.
There is no neuromuscular pathology.
Okay.
And he was off the fentanyl at this point in time when you did this?
Yes, sir. No
Yes,
selection at
sir.
that point.
Okay. Alrighty, so fair enough. So you had a spontaneous awakening trial, and then he was ready to wean, and you gave him an SBT, and he failed.
Yes.
Already, and we talked about two methods of doing an SBT. Do you know of any trial which recently has compared SBT with pressure support versus TPs, which is superior?
Esteban. Brochard.
No?
Esteban and
So this is an NEJM study published 6 months or 9 months ago, comparing spontaneous breathing trial before extubation to assess readiness to using a pressure support ventilation or a TP's ventilation.
So not sure, sir.
Okay, so this is an NEJM published by, I think, 2024. No difference in outcome between spontaneous breathing trials performed with pressure support ventilation or with TPs. So you can use either ways which you use, but when you use a TPs, you need to do this thing. So spontaneous breathing trial, 30 minutes versus 120 minutes.
There is no difference which was observed.
So how long did you give this for this patient?
30 minutes, sir. But actually by 20 minutes, he started to have AF with hemodynamic instability. So we've discontinued.
Just give me a second. Just crazy. I just need to give him quieten him down. Give me a second. Give me a second. Ma'am, you please continue.
Yeah, so Shravani, when do you, yeah, Shweta, you want to go ahead? Yes, please.
No, just wanted to ask, like, how do you determine how long would you give your SBT, like patient to patient basis? How do you determine 30 or 120?
The patient is like on prolonged mechanical ventilation, then we would wait, like also if a patient has background of COPD, in such cases, we'll give
2 hours.
more
A longer SBT.
for SBT than normal. But if not, we'll go for
But
30-minute SBT, ma'am.
You have any evidence between 30 minutes SBT trial and a prolonged SBT trial, and when you give a 30-minute and when you give a prolonged SBT trial? Is there any clinical evidence to that?
Sir, Esteban trial has compared the duration and found there is no much difference, but regarding pertaining to different disease pathologies, I'm not sure the evidence.
Okay, so usually they say that 30 minutes, if the patient is able to do a 30-minute SBT trial, trial, then it's a success of SBT trial. But if you have a failure of an SBT for 30 minutes, the next SBT that you give, preferably after 24 hours, should be a SBT trial, right? Yeah. Yes, sir. You can continue, sir.
Yeah, I'm back. Sorry about that. So somebody on the door. Alrighty. Already. So you failed an SBT pressure support and you developed AFib with Okay, this is the second one.
Yes, sir. This is the following days.
This is the following day. So how do you, what is the classification of weaning failures? What is in the sense like, how do you define simple weaning failure, difficult weaning failure, difficult weaning,
Simple
prolonged weaning?
weaning is when a patient, like after first SBT, if a patient is getting extubated, we call it as simple weaning, sir.
Mhm.
The patient fails up to 3 SBTs or after up to 7 days after the initial SBT. If there is a failure from weaning, then it is difficult weaning, sir. And prolonged weaning is when there is requirement for more than 3 SBTs or more than 7 days after initial SBT. Like
So
select-
the other question that we like to ask is fair enough that if simple more than 3 attempts or 7 days is required, it's you'll call it as prolonged. What are the, so you said in this patient, day 1 had AFib with RVR and today developed tachypnea and tachycardia. So what are the parameters of failure during a weaning trial? So one is on the hemodynamic, you said atrial fibrillation. What else?
Sir, at this point, apart from that, we did not find much clues to.
No. What are the various parameters that you will ask your nurse to monitor when you put somebody on a weaning trial?
So we'll look for the change in heart rate or respiratory. We'll look for
So
the.
when will you call it failure? What should the heart rate be if somebody is in sinus?
Uh,
How do you
20% from the baseline if there is an increase or decrease in the hemodynamics, sir. Blood pressure or heart
No,
rate.
that's sir is asking what is the quantitative estimation of your heart rate? How much?
Then
heart rate?
140.
So heart rate more than 140, as you rightly said, or more than 20% rise from your baseline. Heart rate less than 50 beats per minute, which is bradycardia, and blood pressure maybe greater than 180 or less than 90.
Less than 90.
Or less than 90. So this is the hemodynamic
Rate more than,
predictor of failure. So what about the respiratory?
more than 35 minutes, sir.
Respiratory rate of more than 35 per minute and
Diaphragm.
use of accessory muscles.
Accessory muscles.
What about gas exchange parameters?
Sir, if the PaCO2 is raising by more than 20.
Was it?
I'm not sure, sir.
Okay. So one is obviously gas pH.
pH less
So
than
an increase in
0.2.
increase in PCO2 of more than 10 from pre-weaning value, or a decrease in pH of more than 0.1 from the pre-weaning value, or an oxygen saturation less than 50 millimeter of mercury, or less than saturation less than 88%. It will when we call it as this thing. And neurological condition would be, neurological criteria of weaning would be?
Patient shouldn't have any delirium and
so somnolence, agitation, and delirium. And last is, you shouldn't be having diaphoresis. So there are predictors of weaning failure. They are hemodynamic, respiratory, gas exchange, neurologic, and others. That's how you look at it. So your patient, when you describe these things, when you say weaning failure, you need to, and especially when your challenge is that I need to know to assess what's happening. I need to know what was the heart rate, blood pressure, SpO2, mental status pre, heart rate, blood pressure, SpO2 or PO2 if available, and mental status and other parameters post. Then we will say where is the weaning failure, and then we will have to assess it. So now this is a difficult weaning, second day failure. How do you want to proceed?
so do I go forward or what?
Now, how will you proceed? What would you like to do for the patient?
Sir, assessing for the as you said, like the criteria of failing, like when you look at the parameter changes, but the electrolytes and irregularities, but they were not evidently, there were no dysarthritis evident. Like patient developed tachycardia again, like being with the history of AF per se, we again evaluated for echo, we did POCUS, but we couldn't find any new abnormalities, and we will assess again in the lines of any deranged heart function.
So, do you follow a systematic any approach? Because tachycardia, tachypnea is the final common pathway for any weaning failure. So is this a problem of the
There's
lung? Is this a problem of the heart? Is this a problem of the diaphragm? Is this a problem of a high of an abdominal pathology? Is this a problem of pleural effusion? Is it a what is the problem? How do you assess that?
Ruling out.
So there are 250 causes of weaning failure. At this point in time, I know all 250 are possible. So how do you approach it?
ABCD approach, sir.
Okay. So what was so what size tube did the patient have?
8 size.
8 size. What was the peak pressure?
24. By then it has come.
What was the plateau pressure?
It was around 18.
Guessing, or you're just saying like
No,
that?
sir. By then they have all normalized.
Okay. Alrighty. So the patient had no airway problem, no breathing problem,
No, sir.
no circulatory problem.
No, sir.
No POCUS, no B lines, no increase in B lines,
He was on
no increase in NT-proBNP, no new dynamic changes in ECG. So that's what we are looking at. So when you have a patient who has failed, when you put them on control, back on controlled mechanical ventilation, you do a respiratory mechanics to identify whether there is a problem of airway resistance or compliance. All right. So we've done the POCUS to see if there's failure or not, and you do an NT-proBNP maybe, and you do a ECG to see dynamic changes. So you're left with D. So did you do an ultrasound of the?
Yes, sir.
If your plateau pressure is this good and peak pressure is this good, I don't find there is an intra-abdominal hypertension or any other volume issues with this patient. So it has to be only D. Is that what you found?
Sir, by then we haven't assessed the diaphragm.
All right. Why would you not assess the diaphragm?
He was not stable hemodynamically, so we went.
So why did you even do an SBT if he was not hemodynamically stable?
Assess diaphragm patient has to be on spontaneous small cells, but we had to go back on to controlled ventilation because of hemodynamic instability. So
okay. So what diaphragmatic parameters you can check when somebody is on a volume control mode?
I'm not sure.
How do you assess diaphragm?
Inflection and excursion are normally measured, but do that in spontaneous.
Fair enough. For doing diaphragm excursion, if somebody is on a control mode and is not triggering the vent, you will not be able to do it. Fair enough.
How would you assess the diaphragmatic function if the patient were on a spont mode?
Negative inspiratory force or maximum inspiratory pressure is the ideal way to do, but it's only possible on few ventilators.
How about on the ultrasound?
Diaphragmatic thickening fraction is right.
Okay. How do you get the thickening fraction?
The thickness at inspiration minus the thickness at expiration divided by thickness at expiration into 100. So if it's not, it normally has to be between 30 to 36%, more than that. But if it is less than that, then it will be plus.
Okay. What are the parameters would you check on the POCUS on the lung ultrasound?
Ma'am, if there is any fluid overload pattern like D lines, or if there is any effusions, and if there is any cardiac dysfunction as well, we will look for.
Yeah.
And
you said this patient had. You said this patient had abdominal distension, but there was no fluid thrill or anything. I remember from the examination. Was there any ascites at all? No.
No, ma'am.
Oh, no.
And in ultrasound, they haven't mentioned regarding this.
Okay.
What about the IAP? Intra-abdominal pressures were high. Because acute pancreatitis, volume resuscitated. So we would expect that. So one of the things for weaning failure, if your diaphragm is also good, is that you have a significantly distended abdomen. You have a abdominal wall problem which is causing a restrictive lung disease.
Sir, but the peak and plateau pressures were normal at this point, so
All right, fair enough. So you basically, exactly. So if your airway resistance and lung compliance and lung and thoracic wall, so if your peak pressure was say 55 and plateau was 25, what would you have assumed?
so some tube resistance could be some kinking or any bronchospasm.
So some problem with an airway resistance is what you would have figured. Okay. So the difference between peak and plateau is what you are looking at to say what is happening. So what are the causes of an increased airway resistance? You said tube, which is fine. You said bronchospasm, which is this thing. Any other thing which can happen with prolonged mechanical ventilation?
Sir,
Very good. You're getting there. So you can have an acquired
Malaysia.
tracheomalacia. Very good. Already. And what is the causes of reduced compliance?
Sir, there can be external factors like obesity and spine-related issues, or there can be internal, wherein parenchymal restrictive lung disease.
Okay. Alrighty. So basically you divide them into chest wall problem or a chest wall and abdominal problem and lung problem. So lung problem will be anything that fills the alveoli, pneumonia, ILD, autopeep, so on. And chest wall would be elevated abdominal pressures, ascites, pleural fluid, obesity, edema. All right. What's the diagnostic criteria for WIPE or weaning-induced pulmonary edema?
Sir,
Or do you know of any echo indices of echo guide?
No. The diastolic velocities we look for, sir. Late and early peak diastolic velocities.
How much?
Not sure of the values, but
The gradient of EA gradient of more than 2 indicates failure. So we'll see peak early diastolic flow and with a late diastolic flow in a atrial contraction. If the gradient is more than 2, indicates I can predict
gradient of what? Gradient of what?
Peak early diastolic flow with the velocity and a late
So E by A.
E by A gradient.
E by A more than 2 before and after an SBT, or an E by E prime.
That I can't recollect right now.
See, you are going to be the experts tomorrow. No, who else will diagnose a weaning-induced pulmonary edema? You don't expect the cardiologist to diagnose. So when you do a POCUS for this kind of a failure, of a weaning failure, you looked at B lines, I agreed. You can use a... so already, again, let me ask you, okay, look at the... How do you assess with POCUS the cardiac, the lungs, and the diaphragm? And what are you looking for in a weaning failure? So if you have a... So let me rephrase the question in an exam fashion. What are the failure indices of an echo-guided SBT? So next time, third day, when you put this patient on a SBT, you put a POCUS and you put him on an SBT. Keep the POCUS ready. You do a POCUS before you put him on an SBT. And then you do an SBT after that, isn't it? So there has to be POCUS guided. You said, otherwise, if you put him on a volume control, sir, I cannot check the diaphragm. Then that means you've wasted one day and you've gone off duty. So you have to have you put a probe next day or the same day in the afternoon if the patient is better. So you have to have a cardiac, a lung, and a diaphragm. So you started staying well. So you need to have, so the chances of failure is if your LVEF was say less than 40% before an SBT, the chances that he'll fail may be a little high. And you talked about E by A greater than 2 before and after SBT. The third thing we talked about is E by E prime, which is basically these are indirectly reflecting the pulmonary capillary wedge pressure and saying that you have a left atrial hypertension and a heart pulmonary edema that is happening, E by E prime greater than 13 before and after an SBT. You're looking at the lungs, you're looking at B lines more than 6 on the anterior lung fields. You're looking for a lung ultrasound score if you use greater than 17 before and after SBT, and you're using a diaphragm displacement less than 10 millimeter during SBT or a thickening fraction less than 20 to 30% during an SBT. So this is what you guys need to do, because there is nothing else you can do to identify what else is happening with this patient, especially in the era of POCUS. I would like all exam goers in the DNB Viva to tell me these numbers so that I know that you have been doing these things. Otherwise, I know you have read somewhere, but you're not very conversant with how to do these things. All right. So in this patient, what did you find? Next slide.
So the following day, the shock has resolved and he was tapered off vasopressors. PF ratio was at 288 by now. And we found that there is a decreased power in all of his limbs, sir. And ABG was showing a
All right.
alkalosis.
So we don't like to see power 2 by 5 all limbs. Because the best way to quantify critical illness neuromyopathy is an MRC score. So you have to tell me an MRC score, because MRC score reflects well with diaphragmatic weakness and with overall neuromuscular weakness. I don't need to do for a CINM, I don't need a diaphragmatic ultrasound or a phrenic. If you tell me your MRC is less than, what is the normal MRC? How do you do an MRC score?
Sir, the maximum score is 60, sir.
Okay. What all muscles are there? What all the score?
So 3 per each limb in the upper limbs and lower limbs, sir. So in the shoulder, we'll look for abduction, sir. And the
Very good.
elbow, we look for flexion, sir. And at the hip, we look for extension, sir.
Very
And
good.
coming to the lower limb, at the hip, we look for flexion. At knee, we look for extension. And at the ankle, we look for flexion, sir.
Very good, very good, brilliant, brilliant. And the total score that you can get maximum is 60 and less than
30.
what is suggestive of CINM?
30s. Not sure.
36 is severe, sir. Less than 42 is
Less than 48. So less than 48 will tell you that there is a hint. And also you need to see the DTR. So if you have loss of reflexes, then you know there is it's not only myopathy, there is an CINM also, and it's a loss of sensation. Fair enough. So that's what I would like to see. Power 2 by 5, MRC less than 48. So the reflex is normal, absent. Which one?
The reflexes were absent, sir.
So more CINM.
Yes, sir.
All right.
And however, we proceeded with giving a weaning trial, and patient developed tachypnea, tachycardia at this point, and he was shifted back onto controlled ventilation. No new abnormalities noted in POCUS, sir.
So what abnormalities were you looking for when you didn't know anything?
No, sir, like if there is any fluid overload or cardiac dysfunction.
So it has to be
In
done
terms of-
objectively.
Sorry.
Go ahead,
No,
ma'am.
I just wanted to ask, in case of cardiac dysfunction, you would look for the systolic failure, no doubt. Do you think diastolic failure also has a role?
Yes, ma'am. Diastolic failure has a role.
Can you tell me the mechanism how it can cause weaning failure?
Ma'am, in case of heart failure, like when the patient is on mechanical ventilation, what happens is there will be decreased preload as well as decrease in the afterload. So when we put him on a spontaneous mode, then there will be increase in the preload and as well as increase in the afterload. So this altogether causes a stress on the heart, and thereby there will be an increased stress and failure. So in diastolic dysfunction, already they will be prone to pulmonary edema because of fluid overload. So an additional preload will lead them to further dysfunction.
Yeah, with the spontaneous breathing, the increased venous return, for the stiff heart will not be able to compensate, and that leads to pulmonary edema and weaning failure. Yeah. So another thing you said, this patient was off vasopressors. What if he had been on some vasopressors? Would you still go ahead with the SPT?
Yes, ma'am. Minimal vasopressor support can be accepted to go for rescue.
Is there a number you can think of?
Less than 0.1 months.
Of no rate, yeah. Okay. Okay. Yeah. Carry on.
So there's
POCUS,
a
you said there were
question
no new
from
abnormalities.
audience here, Dr. Shweta, regarding addition to your point. Is there any NT-proBNP done? And if it is done, what was the number?
Sir, it was not done at this point.
But
He is on renal replacement therapy, so we did not actually find.
the value increase of 1380 is more specific for weaning failure, weaning-induced cardiac dysfunction.
Okay. And there's one more question from the audience that is there any evidence for pressure regulated volume control in your patient? You have been using it for ARDS. What benefits do you find with using pressure regulated volume control?
To come down on the driving pressures which are required, we can use PRVC. But regarding the evidence, I can't really comment on it. But if we go ahead with volume control mode alone, then there is high chance that patient gets into barotrauma. And also in case of pressure control ventilation, with improving compliance, we'll have to come down on that, or else the patient will go into volutrauma. So to combat both of these, we can go for PRVC.
Okay, so you get best
UK, we are more
benefits
of
of both.
Both.
Yes, Dr. Shweta.
Sorry, in UK we are more in favor of APRV ventilation. So that's what we use for severe ARDS. More than not much experience with PRVC.
Fair enough. PRVC, I think, is basically just another comfort mode depending on your nurses. It's hardly any difference as a separate mode of ventilation between volume control. It's a little hybrid mode. But again, between volume control and pressure control. In the US, a lot of people, centers prefer PRVC because it just gives you that feeling of safety, at the same time giving you a minimal volume, which your nurses may not pick up when you're in pressure control, or nurses may not pick up the rise in pressures, plateau pressures when you're on volume control. So it kind of does both the job. So people like to use it, but it's not a separate mode of ventilation for ARDS. So if you're looking at ARDS ventilation, you better do the same thing, volume control or PRVC or pressure control. But the idea is to keep the tidal volume less than 6 ml per kilogram at all times. And if you're doing a different mode, then bi-level or APRV is the thing. And there have been good data this year, but a lot of Chinese study, but a lot of good data that APRV might be beneficial in that, but still iffy. But that's not the topic today, so we will skip that. All right, the question of NT-proBNP I'll address. There was a trial called a BMW trial. I can never forget the name because it's brain natriuretic peptide in mechanical ventilation and weaning. Didn't show any, basically if you were to use an NT-BNP level before and after, would it be able to help you? Didn't really do too much. And as the students rightly pointed out, in the presence of renal failure, in the presence of atrial, this thing, it's probably in the recovering sepsis, it probably will not be able to tell you. So I think the going back to the message is when you do the POCUS on this weaning failure, we need to have this the diagnostic criteria. You have to look at the cardiac. So at this point in time, day 5, when the patient failed the weaning, I'm looking at the heart. I'm looking at the E by A, E by E prime. I'm looking at the lung injury score, or how many B lines are there where, and I'm looking at the diaphragm. So the question that we like to ask is, if you're trained in critical care and you're coming for an exit exam, how do you do a diaphragmatic ultrasound? What is the zone of apposition? How do you do that?
In the subcostal region, at the mid-axillary line, we'll go with a curvilinear probe. We'll be assessing for diaphragm.
Diaphragm assessment. Alrighty. So you're using in the what is called as a zone of apposition, where it basically is a lower cage. That's what you do it. And what are the two things that you're looking for? You just mentioned that. But let's
Diaphragmatic excursion
excursion and thickening fraction, sir.
Okay.
The And
When do you check for diaphragmatic thickness?
Sir?
When do you check? Inspiration, end inspiration, expiration, end expiration?
Sir, excursion is between
No. Diaphragm
Thickness.
thickness is checked when?
Sir, thickness, both the expiration and inspiration will take the values, sir. For
But what should be the normal value for? But what you really want to see is how the diaphragm looks when it's not contracting.
Yes,
So
sir.
when you're looking at CINM and you're looking at muscle atrophy and you're looking at diaphragmatic atrophy, what should be the general size of the thickness of the diaphragm at end expiration is what you're looking at, and that should generally be between 2 and 3.5 millimeter.
Yes.
And the thickening fraction should be TDI
More than 30 to 36%.
all right. And what else? Diaphragmatic excursion should be
More than 1 to 1.5.
okay. All right. And with deep sniffs, you can get as high as 5 centimeters.
Yes.
All right. Fair enough. All right. Go ahead.
On day 6, the labs have deranged with elevated neutrophilic leukocytosis and elevated CRP, worsening LFT, and he continued to have persistent fever spikes. He had shock requiring minimal vasopressor support at this point. ABG done was suggestive of metabolic acidosis with lactic acidosis, and MRCP was done to rule out the cause for this deranged LFT, specifically elevated bilirubin, to rule out any obstructive causes, and it only showed a physiological distension, sir, and along with the dependent calculi in the neck region. And repeat cultures were sent, lines were changed because they were from the outside hospital, and SLED was initiated. Following this, on day 7, the TLC counts have slightly come down, but the CRP is still elevated, and fever spikes persisted. Shock was persistent, continued to require minimal vasopressor support, and ABG was suggestive of near normal acid-base balance with minimal lactic acidosis being present. So TE was done at this point to rule out any infective endocarditis because he was having persistent fever spikes and there was no obvious focus of infection that was noted at this point, but it was not suggestive of any vegetations.
Were any cultures positive at any point?
Ma'am, previously they were
sterile, ma'am. Only the ET culture showed
CR club, ma'am, and antibiotics were escalated according to the culture susceptibility report. But despite that, we continued to have fever spikes. Gone ahead for this.
Okay. And you said there was no ascites to kind of rule out an SBP for this man? No. Okay. Okay.
On day 8, he had he was having a persistent encephalopathy, being drowsy, arousable, despite not being on any sedation. And we've done an MRI to rule out any pathology. It turned out to be normal, and so a septic versus a hepatic encephalopathy was provisionally diagnosed, and serum ammonia was done, which was mildly elevated, 76. Persistent shock was present, and he was continued on vasopressor support. ABG was suggestive of a minimal metabolic acidosis, and he had episodes of loose stools which were persistent, and C. diff was suspected, and it came out to be positive, ma'am, for which he was initiated on vancomycin and metronidazole. Blood cultures and ET cultures report have come by now, and they showed no growth. Electrolytes were within normal limits. Following this, on day 9, shock has improved and he was off vasopressor support. ABG was normal, and PF ratios were 331. Electrolytes were within normal limits. So one more trial of SBT was given at this point, but RSBI was 134. Then we have further evaluated as to why there is a failure. And the limb power was 1/5 in all of the limbs. And POCUS was done, which showed a diaphragmatic excursion of 1.1 centimeters, and thickening fraction was 15%. So we've suspected steroid-induced myopathy and critical illness neuropathy. So following this, we got NCS done. It was suggestive of CINM. So we proceeded with percutaneous tracheostomy, and he was gradually weaned off mechanical ventilator onto BiPAP support, and later on shifted to rehab.
How much was the steroid dose he had received?
60 mg methylpred he has received in the outside hospital per day. 60 mg he has received for 4 days now.
Okay.
After that, he was on stress dose steroids in our hospital.
Okay.
So paralytics he received for how long?
Sir, only one session of proning was done, and for a duration of 16 hours, he was on neuromuscular blockade, but after that, he was not on any paralytic agent.
So do we need a nerve conduction study to suggest CINM in this kind of clinical scenario?
It's not required, but
we still do it. Fair enough. In this clinical context.
To proceed with whether or not to proceed with tracheostomy.
No, that's all right. Do you need that decision? So if you have failed, so the question is, when will you time your trach? You have failed 3 times.
Yes.
That means now you're entering into by definition, you have failed more than 7 days since the first weaning, isn't it? You started on day 4 and today is day 10 or something. You have failed 3 times. He's got neuromuscular weakness. He's just recovering from a C. diff colitis. He's malnourished. He's got alcoholic pancreatitis. He's got CLD. Sure, I would do a tracheostomy on him any which way. So I think the question is, one of the questions I forgot to ask in the beginning, which can now be, we go back to the last slide, is, when do you think before you do an SBT, what do you look for? And I think you kind of put this in so what is the readiness trial? How do you know that the patient is ready to be given a SBT?
Sir, when the primary pathology for which we have intubated him has resolved, and if the oxygenation has improved, it being more than 150, and if the pH is more than 7.25, if there is a hemodynamic stability with requiring minimal vasopressors, if the patient is obeying commands, conscious, and also there is minimal secretions, and gag reflex.
So basically the underlying condition has to resolve significantly enough for you to wean, and then the PF ratio more than 150, saturation more than 90%, pH more than 7.25, hemodynamic stability, and ability to initiate an inspiratory effort. So this guy, when he was drowsy, how do you check for respiratory drives? Does he have a good respiratory drive?
If he is able to trigger,
does that check
spontaneous mode?
So ability to trigger, does that check a respiratory drive or neuromuscular strength?
You know something called airway occlusion pressure?
Yes.
Yeah.
Yeah.
So what is that?
P.1.
P0.1 will measure it the second in inspiratory effort. If it is less than 3, it indicates a good effort.
So P.1 versus P occlusion, which one?
Sir,
P.1 is
more reliable than P.1 as per IMS.
So both are basically measure of your respiratory. P.1 is the brief end inspiratory occlusion, typically 0.1 seconds. And while the POCC or P occlusion is the entire respiratory cycle, entire inspiratory, full airway occlusion that you do it. So it takes into account the total patient effort in addition to just the drive. So POCC, this time I think DNB board had a full question or a half 5-mark question, I believe, on POCC, or did we give it in one of our exams? I forgot. but it is a question that we ask. Write a short note kind of a thing on POCC or P occlusion pressures. Okay, so that's something which is important. So when we talk about A, B, C, D, E, B stands for brain, and we need to assess the P.1 or the POCC. POCC is a good measure because it takes into account the A and the this thing, resistive and elastic work also. But most of the ventilators have a P.1 button which you can do on it to identify what the drive is. Alrighty. So, alrighty, ma'am. Any more questions? This is that way. You know, weaning failure is what we like to hear is the same thing. Everybody should undergo weaning. If you should do spontaneous awakening trial every day, you should have a assessment for readiness to wean. Then you do a spontaneous breathing trial, and if you fail, assess why the patient has failed. The important thing is what you have to do is how to assess during weaning failure. So the POCUS criteria for weaning failure, measuring heart rate, blood pressure, respiratory rate, all the parameters that we talked about when we asked you, those are the important things. When you write we didn't talk a little bit about what is called as various indices, which is again a full question sometimes, which is asked for the exam. So when do you use these, say what is a crop index?
It is a product of compliance, respiratory rate, oxygenation, and pressure, maximum inspiratory pressure.
Okay. So so what's a crop index again? Go again. Sorry, it's a little slow.
Compliance, respiratory rate, oxygenation, and maximum inspiratory pressure. More than 13.
No, that's a. No, I thought crop was compliance, the PaO2.
Oxygenation, PaO2, sir, respiratory rate.
Inspiratory pressure.
Yeah, so it's what I remember. I might be wrong because I haven't used this for a long time.
I think it summarizes the effort into maximal inspiratory pressure. So,
okay.
Yeah.
So I think crop index. Yeah, dynamic compliance into maximal inspiratory pressure into the the PaO2 by PaO2 divided by the respiratory rate. That's a dynamic crop index. There's a core index. So when do you use this? When do you use these indices?
So
what is the
prior to initiating an SBT, we'll look for if a patient is on prolonged mechanical ventilation, whether or not we are going to succeed at weaning.
Very good. Very good. So this is basically all these indices are used when your readiness to wean is not easy for you to assess clinically, then you use it. They are not used to assess why you have failed and what to do when you have failed. Perfect. That is exactly what we are looking for. And that means you understand the subject. Very happy. Very well presented, Shravan.
Yeah, well done, both of you.
So,
all right.
Yes, sir. Shall we take some questions that the attendees had?
Yeah.
Most of them are not related to the topic today, but there was a question regarding automated weaning. How does it benefit, and what is the evidence suggesting about automated weaning?
Automated, newer modes of weaning, volume support. So there are a lot of questions that can be asked that way. So I think interesting one is that we only looked at pressure support mode of weaning here. We did not look at volume support. We did not look at using, say, an automated tube compensation with pressure support, or a proportional assist ventilation as a new. So we know the proportional assist ventilation data came out in NEJM paper last year. Didn't make any difference in weaning in proportional assist ventilation, though again it's a closed loop. So the machine learns and you decrease as the work of breathing gets better, you do better. So proportional assist ventilation has been tried. APV has been tried. Automated now computer generated algorithms are trying to help you wean. As of now, the data is not showing any superiority of any one particular mode of ventilation, spontaneous mode of ventilation, or an automated loop, closed loop weaning method to succeed as far as this thing is concerned. But with the way AI is evolving, we probably will end up there. Ma'am, your opinion on this?
Yeah, well, we have a mode called Intel view. We think it's something like a smart ventilator. So it's just a furtherance of the adaptive support ventilation that we commonly use. So in the adaptive support ventilation, we just use a minute volume percentage as a target and we set the PEEP. And by closed loop, again, it determines what's the tidal volume, what's the respiratory rate and everything, and just targets a respective minute ventilation percentage. But in IntelliView, we don't even have to set that. We can get even more lazier. And we just set the required parameters that we need, and it will just start weaning by itself. So it'll reach the minute ventilation thing, but when the time comes for the patient to be weaned off, it reduces the pressure support by itself, it reduces the PEEP by itself. So it basically you have to do nothing and just keep watching. But again, it feels like as a critical care physician, you want more control on the PEEP, you want more control upon how and when to reduce the pressure support and how to manage the tidal volume of the patient depending on the clinical condition of the patient. So these modes I feel are not as smart as proposed. So yeah, again, the data wise, there's absolutely no evidence to support that these intelligent modes are any better than our regular conventional modes, which I think more people are used to. You can assimilate the data well and you can interact with them better. So I think these are still work in progress.
Yeah, so the literature probably says that if you're working in a closed ICU, then probably these automated loop modes are not much benefit. But if you are working in an open-end ICU where protocols are not in place, definitely you should have a protocolized weaning pattern to follow in the ICU. That has shown benefit rather than not having a protocol.
Agree. Yeah.
So I think there's no further questions, sir. We have addressed most of the questions pertaining to weaning, and was one question regarding automated tube compensation. If you have a Puritan Bennett, I'll try to address it. You can use this automated tube compensation. Mostly it is used if your tube size is anything less than 7. Probably your ATC would be of some use during weaning. Either pressure support or ATC could be used. So that answers the last question that was asked in the chat box. So we come to the end of the presentation. Anything final words,
Sorry.
Dr. Smita?
No, just in terms of automatic tube compensation, there's actually no evidence to support this is better over the other. Only when the tube size is smaller, we can consider this is what is the outcome of the data. Yeah.
Yeah, and there was one question like regarding extubating patients to NIV. Would it be of any benefit when you're weaning the patient off? If I would opt for an NIV for an early extubation, would it be the outcomes would be different?
So yeah, extubation to NIV is absolutely, we would say that we don't even look at it as an extubation. So we will say that obviously, even if you have failed a little, not passed the SBT properly, we would still in a COPD type 2 with a type 2 respiratory failure, absolutely yes, where you can absolutely transition them to this thing. There's been again last year there has been an NEJM paper again on looking at high risk for post-extubation respiratory failure, whether getting them onto a NIV will get them beneficial as compared to standard oxygen therapy after extubation. Again, there is good data to say that in a high-risk group, which they defined priori has been defined as presence of heart failure, presence of COPD, and so on. There are 3 or 4 criteria that they use to define high risk. And in the high-risk patient also, extubation directly to NIV rather than face mask oxygen would lead to a probable better outcome. This year, there has been actually one of the things is that once you develop post-extubation respiratory failure, whether NIV is injurious to you, because that's always the worst thing. Once you develop post-extubation respiratory failure, then NIV has to be really carefully thought about. Though this year there's some data that even in that situation you can tend to continue to use NIV very carefully under careful observation. But for today's students and for everybody, post-extubation, once you develop respiratory failure, you should bypass NIV and think of re-intubation. Before they developed respiratory failure after extubation in high risk groups, and especially in type 2 respiratory failure with COPD, yes, it is going to be very useful. In this kind of a patient who's got hardly any movement of his diaphragm, probably no. That is what we would say. So there are certain a priori condition which is called as high risk for post-extubation respiratory failure. Predominantly means acute decompensated heart failure, elderly, and COPD exacerbation. Those are the ones which will really fit well with the immediate extubation to an NIV.
Absolutely, sir. Absolutely agree with you.
Completely agree with you, sir. Yeah.
Yeah. So, if there are no further questions, we have completed an hour of an master class. It has been a really interesting session that we had today, and we are fortunate to have had the examiners, Dr. Suresh Ramsubban sir and Dr. Shweta, join us and share their knowledge and insights on this very important topic. Thank you, Dr. Suresh sir, and thank you, Dr. Shweta, for having given your valuable time for today's masterclass. I'm sure the attendees would have benefited from your expertise. And I would like to thank Dr. Bharadwaj and Dr. Shravani also for making the presentation. And I hope you take back the advice of Dr. Suresh regarding the echo parameters of your heart and lung and diaphragm and the values, that if you get Dr. Suresh as an examiner, you know which question is coming at you next time.
I'll send. What I'll do is, this is from the slide I have. I'll send you the slide. You can share with the this thing. I'll send you a screenshot of the slide for people to memorize.
Sure, sir.
Thank you.
Thanks, sir.
Thank you for accepting and being here. It's always a pleasure to hear to you and interact with you. And
thank you very much. Thanks, Venkat.
Thank you, Dr. Sweta.
Thank you.
Thank you.
Thank you.
Thank you for giving me the opportunity. Thank you, sir. Really appreciate it. Thank you.
Thank you, sir. Thank you all.
Thank you, Karthik.
Okay.
You can conclude the session.
Yes.